Okay, so good evening, everyone, and welcome to another session of Surgical Fix. My name is Fatami Al-Shamari. I am an assistant registrar of general surgery and a member of the Search Kuwait team. I'll be your host tonight. So our session will be about the leak of post-bariatric surgery. It will be given, inshallah, by Dr. Saad Al-Thwaini. Dr. Saad Al-Thwaini is a specialist, bariatric, general, and advanced laparoscopic surgery in Jaber Al-Ahmed Hospital. He is a Saudi board graduate of general surgery. He completed his fellowship in King Saud University in Riyadh in advanced laparoscopic and bariatric surgery. Welcome, Dr. Saad with us.
Welcome.
Hello. So before we start, I'd like to remind everyone to type their questions in the Q&A panels, and we will answer them by the end of the session, inshallah. So, okay. Okay, I'd also like to remind everyone about our next sessions. The links will be shared in the chat panel. To register for the next session, please check the chat panels.
Shall we start or no?
Yes. Dr. Saadi, please, thank you, yours.
Okay.
Yeah.
Assalamu alaikum. We will talk about the leak post-bariatric surgery. So it's like part of the complications of bariatric surgery. So if we would talk about the complication at all as well, there is a lot of complication you should consider when you deal with any complaint post-bariatric surgery. So whatever I'm telling is specifically for the leak. That doesn't mean this should make your focus when dealing with post-bariatric complaints to go through leak, because there is another complaints like portal vein thrombosis, like bleeding, chest infection, wound infection, a lot of things that you should know post-bariatric surgery. So I will specify about the leak. Let's go next slide. Okay. So if we talk about the leak post-bariatric, there is two main procedures. There's a high pressure, which is sleeve gastrectomy, and low pressure procedures like gastric bypass. And there is a surgeries between, like the duodenal switch when we do the sleeve gastrectomy, and we switch the duodenum Saudis or duodenal switch. So we have to apply specifically on the type of procedure. Like, as I said, the duodenal switch is between the two procedures. And any other bypass surgeries like pancreatic diversions, they go, and mini bypass, they go with the treatment of gastric bypass surgeries. The most common thing the most common procedure we're doing now is sleeve gastrectomy, and the higher leak rating is sleeve gastrectomy. So I will specify more details for the sleeve gastrectomy leak. So this is basically what's the sleeve gastrectomy. We all know how we do the sleeve gastrectomy. We put 3, 4, or 5 boards, and we dissect the omentum of the stomach, and then we use a bougie size, whatever, 336. Some people say 40. So it depends on your practice and your data you're following. And then we do stabling all through the stomach along the bougie until we go to the angle of S. Rate of sleeve leak usually is used to be, or let's say 1 to 2%. If you want to talk with the patient, you tell him it's 2%, because you don't want to give him less rate than what we used to know about. But recently, the new studies is telling that it's even below the 0.5%. So with practice, with knowing the pathophysiology of leak and how to avoid leak, the leak is going down. 90% of the leaks are near the gastroesophageal junction, and 10% usually within the first 1 centimeter of the antrum transection. So most of our concern will be in the gastroesophageal junction. So to understand how to deal with the complication and how to avoid this complication, we have to know the pathogenesis of this complication. There is a mechanical factor, ischemic aspects, and personal factor. When we talk about mechanical factor, as I said before, it's a high pressure system. Studies showed when you compare the pressure of the stomach, the normal stomach, and the stomach after a sleeve gastrectomy, it doubled the size. So it doubled the pressure. So the pressure in the sleeve is double than the normal stomach. Why we are having this pressure? Because the antrum, the pylorus is intact. The pylorus function, we know all that the pylorus constrict and relax. So this constriction will cause a backflow and increase the pressure. So this is why we are having more leak in the sleeve gastrectomy. Stenosis or twisting, this is like more of a procedure mistakes or procedure causes. Some people, they go near the angle of near the near the angle, and they cause the structure. So when you do the sleeve gastrectomy, the first two staplers should be away from the angle of the stomach. Otherwise, you will have this kind of stenosis. Twisting usually happens when you take the staplers, one stapler more to the anterior abdominal wall and the other one more to the posterior abdominal wall. So in this way, you will have a stapler like this and another stapler like this, and it will be like halazonia or whatever they're calling. This is bad, and this causes twist. So you have to take the same amount, or every stapling should be anterior and posterior wall should be the same and the same line to avoid the twisting. When suboptimal stapling, when we say suboptimal stapling, that doesn't mean that the staple is away or near. No, it's the function of your hand when you apply the stapler. Some staplers like Echelon, they advise to after you close the stapler, you have to stay for 15 seconds at least to allow the edema to go away from the stapler, and then you fire. Other staplers like the COVID, maybe they don't advise to wait because the stapler is like circle, and by default it will push the edema outside. So you have to know which stapler you are using and how the stapler should function properly. And also when you fire, you shouldn't shake the stapler. When you shake the stapler, the cutting and the stapling will not be in the proper place. So you have to be steady as you can. Don't do it very fast. Don't shake it. Give it its time, recommended time, and then go stapler. Also, when you take a stapler, you should be either on the edge or medial. You shouldn't be in the lateral. If you leave the V end of the stapling, this is an area of leak. So you have to know where your next stapler should be. Now, bougie size, it's a debate. Some people, they say that 40 French and above size is safer and has less leak. Others, they don't agree. I personally don't agree. Bougie 40 may gives you a big sleeve and the patient will regain weight. But if you do the proper sleeving without twisting, without stenosis, and use 36 French or whatever is there, it won't be a big problem. So to be safe, use 40 as some studies recommended. Distant from pylorus, this is also again a debate area. Some people, they said you need to be 4 centimeter or more to avoid higher pressure and causing leak. Again, this in the expense of weight regain. So you should know the best practice, how many centimeter from the pylorus you should cut. So it's a debate area. Ischemic aspect, it's actually all the leaks is ischemic, so which will cause more ischemia. The mechanical factors will cause ischemia. So we should know how the ischemia happen. Usually, in the when you transect the last stapler near the or over the esophagus, we know that the esophagus, the blood supply is not that. After dissection, there is no good blood supply, and also there is no serosa covering the esophagus. So it's better to expose the esophagus first, see the esophagus, take the fat above the esophagus, and dissect it all away from the left crura. Then you will see where is the gastroesophageal junction. Once you see the gastroesophageal junction, you will be safe. You know that you staple away from the junction. Some people, they are more safe. They staple really away from the gastroesophageal junction. This is, again, an expense of weight regain. So you should know exactly how to dissect this area, expose the gastroesophageal junction, and transect just away from the gastroesophageal junction. 1 centimeter means 1 centimeter, not like 3-4 centimeters. Of course, you should avoid burning the wall when you use any burning device like harmonic or ligature. You should be aware how this instrument function. Like in harmonic, the other end is exposed, so you should always keep the functional end of the hot end away from the stomach. And in ligature, maybe it's a bit safer, but again, you should be aware how to use it and not to burn the stomach, especially in that area, the gastroesophageal junction. Here comes the patient factor. If you ask me about all these things, which is the most important thing, I will tell you smoker. Patients with high BMI, usually they do well, even though in literature they say they have more leak. Male, it's difficult than the female, but usually if they are not smoker, they are healthy, they will not have that much of leak. Comorbidities, yes, if we have like more than one comorbidity, not one comorbidity, if you have more than one comorbidity, it may increase the leak rate. So smoking, if I want to talk about something here, I will really insist on stopping smoking before surgery at least 4 weeks. And he shouldn't smoke after surgery at least 6 months. This is a rule for all patients. Otherwise, they will have a very, very bad leak, especially in mini bypass. So let's classify the leak. There is so many classification of leak. Some they classify it from the time of onset or by the clinical presentation, location of the leak, or the radiological appearance. We should know all of this because it will help us on understanding how the treatment will be chosen for each type of leak. So usually when they say acute, it's in the first week. This is specified for the sleeve gastrectomy, not for the bypass. So acute is less than 7 days. Early, which is the most common, from 1 to 6 weeks. Usually it is between, it is the mean time of leak post bariatric surgery is 12 days. So early is the most common time of leak. Late, which is 6 to 12 weeks, and chronic more than 12 weeks. When we talk about clinical presentation, there is 2 types of classification. One is that the patient has a localized, contained, without dissemination, which is then the most common one. When the patient come with fever, with tachycardia, abdominal pain, nausea, vomiting, shoulder pain, all these common complaints, they usually have what we call the type 1. Type 2 is where there is rigid abdomen, the leak is disseminated everywhere in the abdomen, and this type of leak needs an urgent operation. Again, radiological, they are finding, I don't know which scenario will lead you to find the type A radiological finding, but usually it's like just micro bubbles along the stapling line, but the patient have no complaint or they have unspecific complaint. Usually we found this in patients who come with pancreatitis, and we do a CT and we found some bubbles on the stapling line. They said, okay, there is maybe query microperforations. And these patients, usually we have to deal with them as leak. So we start antibiotics, we do gastrography study to make sure there is no any hidden leak that's not shown by CT, and then we complete the course and reassess the patient. Usually they do well with antibiotic only. Then type B and type B and type C. The type B, there is a radiological finding, but without clinical finding. Usually they say, some people, they call it, this patient is having a concealed leak, which is really bad terminology, because once there is leak, it should be treated as leak, even if there is no clinical findings. So if you have a patient who did a CT for whatever reason, nausea, vomiting, and you found a leak on CT, you should treat it as leak, not as concealed leak, because later on they will develop a fistula, and this we see it a lot. When I was doing my fellowship in a referring hospital, so all the mistakes being done all over the kingdom, they refer it to our hospital. So I see this kind of management. So once there is any leak, any collection, you should treat it even if there is no symptoms. Type C is there is evidence of leak, and there is also clinical evidence of leak. Okay. Location: proximal, middle, distal. As I said, 90% of them are in the 90% of them are in the proximal, and 10% usually in distal. Okay. If somebody asks you which is the most important sign of leak, immediately tell them tachycardia, because almost always there is a tachycardia. And if any patients come to the ER and they call me, hello, the fellowship of the fellow of upper GI, we have a patient post bariatric, immediately I wait for the heart rate. If he tells me the heart rate more than 100, I will come immediately. Because always any tachycardia above 100 should taken seriously, and usually if it's more than 120, it's almost always there is a leak. Fever, tachypnea also, abdominal pain, left shoulder pain, peritoneal stenosis in the late presentation. Nausea, vomiting also, they will have this complaint. So the most important modality of diagnosis of leak is CT scan. Any other modality is just delaying the diagnosis, unnecessary modality of diagnosis. If you have a patient and you want to diagnose him, you should do a CT scan. And usually, if it's sleeve gastrectomy, if it's not bypass, we just need an IV contrast, of course, and also 1 cup of contrast on the table. So when the patient is going for CT, once he is on table, we drink he drink 1 cup of contrast, and then we do the CT scan. There is no need to wait for to complete the contrast or waiting for 2-3 hours. Just 1 cup on table of the CT scan. Always in the initial treatment, you have to resuscitate the patient. Stabilizing the patient is the most important thing for doing anything, for doing CT, for doing any other investigation. So resuscitate Usually, if there is a patient who if you suspect leak, you should start antibiotic, start dose. Tazocine is the preferred antibiotic usually. Also, plus minus antifungal, not everywhere. I will tell you about this later on. IVBPI and antiemetics, one dose if he's having nausea, painkiller, and do chest X-ray. Chest X-ray is very important as a very fast modality to have suspicion of leak. Usually, like 80% of them, they will have pleural effusion, left-sided pleural effusion. So when you see a pleural effusion, you put in mind that this patient is high, may have a leak. So treatment. Then if you know the concept very well, the treatment will be easy. Any modality of treatment should all come to the concept of treatment. First of all, prevent sepsis. By draining, by antibiotics, by resuscitation, any modality that prevents sepsis is the first most important modality of treatment. So prevent sepsis, drain any collection, divert feeding from the leak. So the food should go to the alimentary, avoiding contact with the leak. Restore nutrition either by internal or TPN. Internal is always the preferred route, and then allow time for healing. If there is an obstruction, you should deal with it, because otherwise the leak will come again, and it will convert to a chronic leak or fistula. So now we have, if we want to split the management to stable or unstable patients, in unstable patients, almost always the treatment is exploitative laparoscopy. There is no time to give antibiotics or do a CT scan. So if the patients have rigid abdomen, you know this patient has unstable hemodynamically, you just resuscitate him, give him good fluid, and shift him to the OT. In OT, you should be prepared always. With 2 sections, you should put 2 sections, you should put another inflating machine. Sometimes it's very hard with section that the air, when the air comes in from the inflator, immediately sucked away. So if you have another inflator, it will help you with dealing with the intraoperative spacing. So the principle of exploitative laparoscopy is drain the collection. You should drain all collections, especially above the liver, because this is the area where most of the people, they forget about it, or they drain it less. So you should drain very well. Drain, of course, the area of the leak. Drain the pelvic area. It's like if you are doing the peptic ulcer perforation, duodenal perforation. You should clean any debris in the abdomen using a mop, a wet mop. Mop all the debris, take it out, clean again, use 7 liters of warm water. Make sure it's warm, otherwise the patient is hemodynamically unstable and he may go with coagulopathy. So drain everything very well. After that, do not attempt any repair. Even if you see the leak and you're sure this is the leak, don't put any stitch. Just leave a drain near the leak and leave another drain behind the spleen, because this is the area any escaped leak will go to behind the spleen. So leave 2 drains and then see which is the best modality of feeding, because feeding is the most important thing to allow healing. Some people, they put an NJ and intraoperatively. Others, they use the duodenal feeding. If you find any clear twisting or obstruction, and you elect to go for stenting, this is another option. You can do it intraoperatively, stent the obstruction, and leave the area to heal. And this has an advantage of starting oral feeding after that in 1 or 2 days. So drain everything, do not repair, divert feeding, and place 2 drains. In hemodynamic stable patient, which is the most common presentation, you should act fast. As I said, if you have a suspicion, send them for CT. After CT, you should contact interventional radiologist for a CT guided drainage, which is the most common procedure used. Another modalities of drainage is what we call the double pigtail. Endoscopically, we put this double pigtail, one inside the cavity and the other intralaminar, so it will drain whatever goes to the cavity back to the intralaminar. It's a newer modality. Here in Kuwait, we are doing it more often nowadays. I personally have no experience with it. Other modalities, if you don't have interventionist and there is no endoscopist to do detail, you can do a laparoscopic wash and drain placement, as we said, with the unstable patient. Option of diverting and healing. Endoscopic stent is the let's say the most popular one. We use the mega stent. It's a long, wider stent that could cover the whole stomach from the post-pylorus until the esophagus, so it will give you a good sealant of the leak. Double pigtail again considered a diverting. Clipping like Obisco clips, it's not really a good option, but it's there. Sometimes you need it and it may work. Fibrin sealants, also another option. Evac, nowadays they are doing it in the UK. I've been through multiple studies, but it's really time consuming and needs multiple sessions. So this is what we call leak drill. This is a diagram that we implement where I used to do my fellowship. Any patient suspected leak, we have to resuscitate antibiotic stat, IVPI, and paracetamol, etc. Do urgent CT scan with 1 cup on table and IV contrast. Within 12 hours, we should do a CT guide drainage. Within 24 hours, stent should be placed. TBN should be placed through a PICC line within the first 24 hours. And after 24 hours of the stent, we do a contrast swallow. If there is no leak, we start feeding within 48 to 72 hours. Clear fluids. Usually, the patient will stay for 5 days and then he can go home. This is a picture of leak. We can see the whitish area is the staplers, and this is the lumen, this is the staplers, this is the area of collection. This is how we do the CT guided drainage. After the drainage, we go for the stenting. So you shouldn't do stent before you do drainage, because when you put the stent, you will make a closed cavity. That the collection cavity will be closed from inside and outside, so it will be an abscess. It's dangerous to put the scope before you drain the collection. So first of all, drain the collection and then go for whatever endoscopic modality you would like to do. The result in the early leak, which is the most common leak, are excellent. Usually 70 to 80 to 100% success rate. It's different from one study to another. But personally, I see most of them in the early leak, they healed 100%. Maybe in the late leak, it has less success. And of course, in the acute leak, we use it only if we have a twist or stricture and we'd like to relieve it post-operatively, we place it intraoperative. So it's very important to know how to choose the right stent. Because when you deal with the complication of leak, you should know all the type of stents and when to use this one instead of the other one. There's different sizes, length, different material. Some of them are custom made. Still, it's an off-label because it's designed for malignant structure and fistula only. But there is a lot of studies about it, and the efficacy is, as we said, it's 70 to 100% success rate. So people still use it, and I personally use it if I need. We call a self-expanded stent. Stents. There is a cross-hatched of metallic material. There is also a plastic material, but we use almost always the metallic material that gives you radial force and luminal friction. This is the picture that shows how the stent looks like from the endoscope inside. Partially covered or fully covered. This is a debate always continues to be there. The good thing with fully covered stent is that there is no ingrowth of mucosa inside the stent. So because it's fully covered. But the problem is it has a higher rate of split, of migration, around 46%. With the partially covered, we can see here proximally and distally, there is an area without coverage. This area will cause mucosal ingrowth, but will give us a firm hold in position, so there will be less migration, around 15%. Also there is another type of stent, which is the plastic one. Plastic one, usually we don't use it as the primary modality, but I will tell you later on how we use it. This is what we call the mega stent. There is a mega stent, there is an ETS beta stent, and there is a Hanoro stent. They are specially designed for the sleeve gastrectomy leak because they are long and they have a wider diameter. They are around 18 to 24 centimeter, and also the diameter is between 26 to 28 millimeters. So it has a very long coverage area. Some people, they place it pre-pyloric, some they place it post-pyloric. I personally, my experience with the post-pyloric fixation, and I think it's the best place because it gives you a more firm holding in place from the post-pyloric until the esophagus. This is what I told you about the plastic stent. Usually I use it only for stent over stent. So when we use as I told you, the partially covered, it's very hard to take it away. So on day of removal, before removal, we place the plastic stent over the partially covered stent, so it will cause necrosis of the mucosa that has been grown in, and we leave it for 1 to 3 weeks, and then we pull both stents together to be easier to pull together. Biodegradable stents, also it is in the market, but I personally have no experience, and there is limited data to recommend it. The good thing is with biodegradable, it doesn't need removal. It will degrade by itself. So here's the most important part, is the post-stent care. You should know that in the first 48 to 24 to 48 hours, you should restrict the patient from taking any liquids, because the movement of the esophagus, the movement of the stomach, it may migrate the stent. So it's better to let it settle down, let it take its shape, fully expand, and fix in place. After that, you can do a gastrography to check that there is no parastental leak, or there is no any and the area of leak is fully covered. Any patient on stent should be on PPI until he removed it, or you can only continue after removal for at least 2 months. IV antimetic, because most of them, they will have a reflux, So you should educate them to lie in 45 degree and also take anti-emetic medication once they need it, and PPI also. The time of stenting shouldn't exceed 8 weeks. 6 to 8 weeks is the recommended time. Otherwise, you will have more complication and removal. This is the double pigtail we talked about. The good thing is that there is no need for external drainage, no need for CT guide drainage, no need for stenting. Toleration, patient tolerated very well, but it's good only for the smaller leak, less than 10 millimeter. If the leak is less than 10 millimeter, you can use the double pigtail. The other disadvantage is that it needs more than one session, so you need to change it an average of 3 sessions, and usually it takes 3 to 6 weeks to change every time. Success rate is around 70%. This is the clip, the avascular clip. It may be good if you have a leak in the antrum, because when you go on the scope, you can see the antrum easily and you can grab it and you can clip it. But in the gastroesophageal junction, it's very hard to move the scope and see where is it. And believe me, when you put it inside, it is very big and you don't know how to deploy it. So, and also the results not that much, so it needs more study and more techniques. EVAC is they have a good result, but which is around, they're telling around 100%, but they need an average of 7 times changing every time under GA. Every 3 to 5 days you have to go under GA and take the sponge. The idea is there is a sponge connected to a tube, same as we do the back for the diabetic foot or for the abdominal wall closure. We put it in the cavity here and we connect it to the section. Every 3 to 5 days it has to be changed. And usually the success rate is around, they are telling around 100, takes around 35 days and 7 different changes. This is how it looks like, the leak from the endoscope. See the small dot here, this is the leak. There is another small dot here, this is the leak. See these bubbles, most of these bubbles are saliva. When we talked about stent spillage, there is another modality to prevent the fully covered stent to migrate, is they using the endostitch. Here in this picture, the endostitch, they use the endoscopic stitch to stitch the stent on the esophagus. Okay, when I talked about fungal infection and the use for antifungal, this is a study I've done in King's Road University, where I included around 31 patients post-leak, and I go through the data of the culture. I found that most of the cultures are Candida, 62% are Candida, and 58% are bacteria. So adding the antifungal in the treatment will be a good option to process to increase the healing process. So if the leak failed to close, usually this is what we call it a chronic leak, because we attempt different times after 12 weeks. Let's say 12 weeks usually is the time when we say this leak is a chronic leak. And usually these chronic leaks, if left untreated, they will go to develop gastrocutaneous or gastropleural or gastrobronchial or gastrocolic fistulas. These pictures are mine, actually. The real patients in my fellowship, you can see there is NJ feeding, because after multiple stenting, patient refused surgery, so we put her in NJ feeding in an attempt for healing. Unfortunately, it's not healed. See that there is a gastrobronchial fistula. This is another view of the same patient. This is another patient. This was the First time I saw it in the emergency, I did the CT scan. She had a chest infection. CT scan, there is no leak, so I was really suspicious that there is a leak. So I asked for a gastrography. So this is again, if you know all the modalities, you may use them if you have a high suspicion. So CT scan, there was nothing. So I did the gastrography, and this was the shocking picture. There is a leak that is connected to the bronchus. And this patient did the surgery somewhere else and admitted in our hospital as chest infection. After 3 or 4 days, they called me, doctor, we need to know what kind of feeding we can give this patient because this patient did sleep gastrectomy. I said, why the patient is admitted? I said, chest infection. How many days post-op? They said 10 or 12 days. I said, this is leak. They said, no, there's no leak. We did CT scan, there is no leak. So I went in, I checked the CT. Okay, there is no leak, it's very clear, but I had a higher suspicion, so I did a gastrography, and this was the finding. This patient was treated non-operatively, fortunately. I remember she was an old lady. We did stenting, and it was marvelous. When we removed the stent, there is no any more fistula. This is another picture of a patient with gastrobronchial fistula. This is a gastrocolic fistula. You can see the colon here. It's whitish from the contrast. The contrast goes from the stomach to the colon. And this is a gastrocutaneous fistula. See, it goes all the way to the abdominal wall. So in these cases, when you have a chronic leak or a fistula, the option is almost always surgical. There is different kind of surgery. The most effective one, but needs, but it carries a higher morbidity, is the total gastrectomy and esophageal See the picture on the right. This is the esophagus in the top, and it's connected to the jejunum. Esophageal This is the, I think the procedure that has the highest success rate. Some other people, they do a fistulojejunostomy, usually by going through the medial crura until through the raw area and trying to lift up everything and find where is the fistula exactly, trim it down, bring a roll in, and do a hand sewing anastomosis. It works also because it relieves the pressure and drain anything that is drained from the fistula. Row Y, this one has the least success rate, but I've seen it works when you relieve the pressure, especially if there is a twist or a stricture that is not treated with couldn't be treated with a stenting. You can do a relieving procedure like Row Y by cutting above the stricture of the twist and do a Row Y gastric bypass. And this is how we relieve the pressure and allow the area to heal. So these are the three procedures. I don't want to go more in details, but you have to know the procedures of choice for dealing with chronic fistula or chronic leak. This is how we do the total gastrectomy and esophageal. Okay. Most of the information I told you during the subject covering that the sleeve gastrectomy is the same for the bypass leak, but usually there is some mild differences. Usually, just 1 second.
So we apologize for the interruption. Dr. Saad will be soon with us, inshallah.
Sorry for the close the door, please. Okay. Sorry, Shabab, but there was something urgent. Okay. Are you there?
Sure. Please continue, Victor.
Okay. So, Rowan, the treatment is, or the principle of treatment is almost the same, but there is small differences. The incidence of leak in Rowan is less than the sleeve gastrectomy. Some people say it's 0, and some other studies say it's around 5.6. But in total, it is less than the sleeve gastrectomy. Most of the leaks happen in the gastrojejunostomy, around 42 to 67%. After that, the gastric pouch, we can see in the picture here, A is the gastrojejunostomy, and then the gastric pouch, C is the remnant stomach, and D is the jejunostomy. The nightmare of leaks is the jejunostomy. If it happens, the mortality is around 50%. And unfortunately, usually the signs and symptoms is not that obvious. So you should have a higher suspicion if you have a patient with signs of fever or tachycardia to do a CT scan to check if there is no leak. Here it's different. Majority they occur within the first 3 days because most of the cause is technical. Either the stapler, there was error with stapling, or there is a tension on the gastrojejunostomy. So it happens earlier than the sleep because there is no the other causes with pathogenesis we talked about in sleeve gastrectomy, the high pressure, the ischemic or the twisting. Usually there is no. Usually the pressure is less in gastric bypass. So either it's almost always the cause is tension in the anastomosis, or there is technical error with the stapling. So again, tachycardia is always the most important symptom to look for. Abdominal pain, tachypnea, fever, oliguria, all other causes, all other symptoms of leak. CT scan again is the same, the gold standard modality of diagnosis. You should always, if you have suspicion of leak, patient tachycardic or feverish, you should do a CT scan. Again, same principle, stabilize the patient and treat the infection. Same list of management, resuscitate, antibiotics, IV BPI, painkiller, and do chest X-ray. Concept is the same concept: prevent sepsis, drain the collection, divert feeding, restore nutrition, allow healing, and deal with any obstruction. In hemodynamic unstable patient, usually is the same thing. We have to go for laparoscopy, explorative laparoscopy. And here we do the same principle, 2 drains, and we have to have high flow, try to clear any debris, any collection everywhere, and wash the whole abdomen with the warm saline, 7 liter. The difference is that you can do a repair if you see where is the leak here. Because the difference is that here it's not an ischemic leak, it's a technical or a tension leak. So you can do a repair or a Graham patch after trimming healthy edges. Also, the diverting the feeding, you can do same NJ feeding, or you can do a gastrostomy through the remnant or the excluded stomach for feeding, or jejunostomy feeding tube. Same, you have to place 2 drains near the leak and 1 behind the spleen. In hemodynamic stable, which is the most common again, you should act fast. Same principle, percutaneous drainage if there is a leak. Double bacterials also can be used there. Laparoscopic type of washing and drain placement is also always there if there is no other modality, unless invasive modality. Option of diverting, usually draining the leak is enough with bypass leak. Usually there is a higher success rate, and there is no need for any other endoscopic modality. But if you need it, you can go with the same process, either by doing a percutaneous CT-guided or ultrasound-guided gastrostomy feeding tube and the excluded stomach. That will allow the gastrojejunostomy area to heal over time and the patient to have a high nutrition that will increase or fasten the healing time. Endoscopic stent, pigtail drain, clipping, all other modalities, injection and evac always can be used when needed. So if you have a chronic leak or a non-healing leak, there is always the surgical option. Here it's, let's say, easier, but not easy procedure, but easier than the total gastrectomy and esophageal. You can just take down the whole anastomosis where the leak is there and do a fresh anastomosis, and things will be good. Thank you. I'm done if you have questions.
So, Dr. we will wait a few minutes just to check with the Q&A panel if there is any questions.
Okay.
Doctor, we have a question by Dr. Abdelaziz Yahya. You want to read it? Well, I should read it. It's in the Q&A panel.
Trying to see it.
Do you want me to read it?
Yeah, please, because I can't.
Okay. Okay. So he's asking, what is important of color leak, like if pink or yellow?
The color leak.
Yes.
Blue is the best, because if you have, does he mean coloring, food coloring, or what does he mean?
I'm not sure. The question was, what is the importance of color leak, like if pink or yellow?
Okay. If he means the food coloring test, which color to use for the food coloring test? Blue usually is the food coloring test we use. If you have a drain placed after surgery and you want to check there is a leak post the procedure, you ask the patient to drink a blue food coloring and check the drain if there is any leak. Because usually red there is blood, yellow there is maybe secretions. Any other color, green, maybe there is a bile. So blue, usually there is nothing blue in the body. So blue is the color we use for food coloring. Is this a question, or maybe he means something else?
No, this is the question. Probably yes.
Probably.
Yeah.
Okay. So maybe I just put the information. A load of information to you. I don't know if this is helpful, or I just throw everything on you. I don't know. So don't be shy to ask any questions, especially if you don't know anything about this subject, or you have or this is a new information to you, just ask it and we can answer it together.
Okay, we'll check if there's any other questions.
نشوف إذا نايمين ولا صاحيين. Can we ask which what is this in the picture? If we can give him a multiple choice question, is this a gastro bronchial or gastrocutaneous or gastrocolic? We can do this as a.
We sure can.
Hmm?
We sure can. Please feel free to answer what Dr. Saad asked in the chat panel. So Abdurrahman Hussein answered gastrocolic. Yeah, so far only Abdurrahman answered. Is it correct?
Okay. So, okay, let's go back. So, if you for the residents, either R1 or R5, if you want to go out with an information, the most common or question that usually they ask in the exams, what is the most important sign of leak, tachycardia? What's the best modality of diagnosis, CT scan? What's the principal treatment is drainage and diverting? So this is the principle of how when you deal with bariatric leak. If the R5 want to ask anything surgical, technical, I will be more happy to answer their question.
Doctor, there is a question by Abdurrahman Hussein. He's asking about your experience with buttressing materials, types, and preferences.
Okay. So usually in the market there is different type of buttressing. Some of them they come with the same company like Covidian. They have really buttressed stapler that comes stapler with buttressing material in place. And this is what I usually use for the echelon. You have to bring a buttressing material from other company like berry strips they call it, or the Gore company buttressing material. But I personally use the Covidian one, and I found it very good. But you have to know that it doesn't prevent leak. It only prevents bleeding, and some people they say by preventing bleeding you prevent leak. So we use it only for bleeding. Nothing has been published or evidence-based conclusion that there is a decrease in the leak in used buttressing material. Other modalities is the using the sutures by invaginating the stapler line, taking part of the posterior wall and anterior wall and tie it together, so you can do like invaginating the stapler line inside. And this could be more feasible and it causes and it prevents leak more than the buttressing material.
There's another question from Abdulrahman Hussein. He's asking manual versus electrical staplers, your preference and why?
Okay. There is actually there is no much difference between them, but the electric staplers, they have the advantage that you don't need to move the stapler while you are stapling, so to cause less shear or movement of the stapler while stapling. The company claims that it has a better result by addressing the thickness of the stomach and accordingly moves the speed of the stapling either fast or slow, depends on the thickness. So it's a good one. I can use it. I have no problem with using it. I've used it a lot. And the manual, I have also no preferences. I can use both at the same time.
Okay.
Good.
Okay, so apparently there are no more questions. Thank you, Dr. Saad, for your informative lecture. It was really enjoyable to watch. So thank you. So before we end the session, I'd like to announce our next session, which will be a continuation for what we had tonight. It will be given by Dr. Jaber Al-Ali. He will be giving us an endoscopic perspective in managing leak this Tuesday, inshallah. You can also, sorry? It's a continuation for your lecture, Doctor.
Most of the talk is about the endoscopic management.
Yeah.
If I knew, I would take it off and do more surgical.
يعطيك العافية. Okay. So you can also register for everyone still attending. So you can also register for the next ABC of Research session given by Dr. Sarah Al-Yoha on July the 1st. It will be about how to write a paper for publication. Please know that all our sessions of ABC of Research, also Surgical Fix, are CME accredited by the American College of Surgeons. Please feel free to scan the QR codes in the screen for an easier access for registration page, or you can use the links in the chat panel. Thank you everyone for joining us, and you guys have a good night.